Okay, so trauma and stress. So this is chapter 13 in your Vitabac book. So our objectives for this PowerPoint is to describe responses to trauma and stressors. Specifically, we're going to talk in detail about post-traumatic stress disorder and dissociate identified disorder, applying the nursing process to the care of these clients with trauma or stress-related diagnoses, examine the occurrence of various longer-term responses to trauma and stress, provide education to clients, families, and communities to promote prevention and early intervention for trauma and stressor-related responses, discuss the characteristics, risk factors, and dynamics of immediate and longer-term individual responses to trauma and stressors. Evaluate your own experience, feelings, attitudes, and beliefs about responses to trauma and stress. Describe personality disorders in terms of the client's difficulty in perceiving, relating to, and thinking about others and the environment. Discuss factors thought to influence the development of personality disorders. Apply the nursing process to the care of clients with personality disorders. Provide education to clients, families, and community members to increase their knowledge and understanding of personality disorders. And evaluate personal feelings, attitudes, and responses to clients with personality disorders. All right, so this is what we're going to talk about tonight. Some of our exemplars. I do have a quick little thing for you guys to watch. Oh. Oh, wait a minute. I gotta share this, I think. Gotta give you permission to.
Dr. John Kenworthing, welcome to the short tutorial on your brain on anxiety and stress. It is essential to know how our brain responds to the stimuli which trigger an anxiety response so that you are equipped to deal appropriately with anxiety. Let me highlight the key areas of your brain that are involved, and then
sorry guys.
I will explain what happens inside the brain. The thalamus is the central hub for sights and sounds. The thalamus breaks down incoming visual cues by size, shape, and colour, and auditory cues by volume and dissonance, and then signals the cortex. The cortex then gives raw sights and sounds meaning, enabling you to be conscious of what you are seeing and hearing. And I'll mention here that the prefrontal cortex is vital to turning off the anxiety response once the threat has passed. The amygdala is the emotional core of the brain, whose primary role is to trigger the fear response. Information passing through the amygdala is associated with an emotional significance. The bed nucleus of the stria terminals is particularly interesting when we discuss anxiety. While the amygdala sets off an immediate burst of fear, the BLST perpetuates the fear response, causing longer-term unease typical of anxiety. The locus coeruleus receives signals from the amygdala and initiates the classic anxiety response: rapid heartbeat, increased blood pressure, sweating, and pupil dilation. The hippocampus is your memory center, storing raw information from the senses, along with emotional baggage attached to the data by the amygdala. Now we know these key parts, what happens when we are anxious, stressed, or fearful? Anxiety, stress, and of course fear are triggered primarily through your senses. Sight and sound are first processed by the thalamus, filtering incoming cues and sent directly to the amygdala or to the cortex. Smell and touch go directly to the amygdala, bypassing the thalamus altogether. This is why smells often evoke very powerful memories or feelings. Any cues from your incoming senses that are associated with a threat in the amygdala, whether that threat is real or not, current or not, are immediately processed to trigger the fear response. This is the expressway. It happens before you consciously feel the fear. The hypothalamus and pituitary gland cause the adrenal glands to pump out high levels of the stress hormone cortisol. Too much cortisol short-circuits the cells of the hippocampus, making it difficult to organize the memory of a trauma or a stressful experience. Memories lose context and become fragmented. The body's sympathetic nervous system shifts into overdrive, causing the heart to beat faster, blood pressure to rise, and lungs to hyperventilate. Perspiration increases, and the skin's nerve endings tingle, causing goosebumps. Your senses become hyper-alert, freezing you momentarily as you drink in every detail. Adrenaline floods to the muscles, preparing you to fight or run away. The brain shifts focus from digestion to focus on the potential dangers, sometimes causing evacuation of the digestive tract through urination, defecation, or vomiting. Heck, if you're about to be eaten as someone else's dinner, why bother digesting your own? Only after the fear response has been activated does the conscious mind kick in. Some sensory information takes a more thoughtful route from the thalamus to the cortex. The cortex decides whether the sensory information warrants a fear response. If the fear is a genuine threat in space and time, the cortex signals the amygdala to continue being on alert. Fear is a good, useful response essential to survival. However, anxiety is a fear of something that cannot be located in space and time. Most often, it is that indefinable something triggered initially by something real that you sense, but that in itself is not threatening, but it is associated with a fearful memory. And the bed nucleus of the striatum perpetuate that fear response. Anxiety is a real fear response for the individual feeling anxious, and anxiety can be debilitating for the sufferer. Now that you know how anxiety happens in your brain, we can pay attention to how we can deliberately use our prefrontal cortex to turn off an inappropriate anxiety response once a threat has passed.
Okay. All right, so there are a couple different videos. I think it's in these slides. I left them all in there for you guys to look at. We're not going to click on each one of them because some of them are a little bit long and it would take us a long time, but they're embedded in there. So at your leisure, you certainly can click on them and watch them. All right, so traumatic events and stressors. We know that anybody can be affected by any type of traumatic event at any given time. We all pretty much have stress in our life. School, work, raising kids, sometimes it's good stress, weddings, things like that. Clients can develop a trauma or a stress-related disorder following any exposure to any type of traumatic event. We see this primarily with our military personnel who go over and they fight in war and they see some pretty heavy-duty things. And then extreme stressors. So an unexpected death of a family member, if you have a history of any child abuse, and if you have ever been through a natural disaster like a flood or a hurricane or something like that. It's important as nurses that we know how to care for these people. You will see a lot of these people in your everyday life. They might not tell you that these things are going on, but they carry this with them. And it is going to affect the care that you provide to them. So characteristics of a traumatic event are experiences that are extraordinary in intensity or severity. And they might not be severe or extraordinary to everyone. I mean, the way you handle something and the way I handle something may be two different things. So we also have to understand that you might not always view the traumatic experience that the person has as a traumatic experience. It might not seem like that big of a deal to you, but because they've experienced it and that's how they feel about it, it is a traumatic event. So anything that's extraordinary in intensity or severity, and then stressors that are beyond the stress of everyday life. So how stress is defined is basically just wear and tear of life on the body. And that's a pretty good definition. Our body kind of signals us, alarms us when we become in like a stress mode. We build up a resistance to fight that stress. We can only go for so long before we have physical exhaustion and mental exhaustion. You guys are probably starting to realize that just from being in school. Here's another video.
Microban 24 doesn't just kill bacteria once then stop. It keeps killing bacteria for 24 hours. Just spray and let dry to form a shield that's proven to keep killing bacteria for 24 hours. Touch after touch. Microban 24.
This episode of D News is brought to you by the Toyota Corolla. Let's lead the way. Oh my gosh, I'm so stressed. Oh my god. Oh gosh, this is the worst. Oh, I think I'm gonna throw up. Hey guys, Julia here for D News. Stress is really, really awful for your body. You know when you get scared, embarrassed, or anxious, your face flushes and you get all hot and sweaty? Well, this is called a psychogenic fever. Your body temperature actually increases when you're stressed. It's warming up the muscles in case you need to get the hell out of Dodge. Most of the short-term effects of stress are the result of this fight or flight response. The adrenal gland, which sits on top of your kidneys, releases the hormones in response to some stressor. This in turn releases glucose into your bloodstream to power you up, ready to take on a threat. It suppresses your digestion and immune system to save energy for hightailing it away from like a bear or something. But nowadays, we aren't threatened so much by bears, but school, work, and family matters stress us out just the same. All of those good things that those hormones do to save us from bears do bad things to us when we're faced with chronic stressors we can't run away from. One of the hormones, cortisol, is called the stress hormone, and it does a lot of different things. It can affect your blood pressure, metabolism, and immune reactions like inflammation. Basically, chronic stress makes your body continually release cortisol. Normally, this hormone keeps inflammation in check, but after a while, your cells get burnt out and become less receptive to the hormone. Inflammation then kind of runs amok and causes its own host of problems. Inflammation can lead to heart disease and obesity, and is now being implicated in some mental health disorders like depression and anxiety. Inflammation can also damage your DNA. The study, published in the Proceedings of the National Academy of Sciences, found that stress damages your telomeres. Telomeres are often compared to that plastic tip on your shoelaces. They sit on the ends of your chromosomes to keep them from unraveling. As cells divide and DNA replicates, these telomeres shorten throughout your life, eventually leading to cell death. The erosion of telomeres is a pretty good indicator of someone's health. Smokers often have shorter telomeres than non-smokers, for example. In this study, the researchers found that displaced Indian villagers had shorter telomeres than other villagers who didn't go through the stress of relocating, which is similar to other studies on the effects of stress on telomeres. But it's not just having your entire village moved. The American Psychological Association found that Americans are most stressed about work, money, and the economy. Does this sound like you? If you're chronically stressed, there is some hope. Being socially connected helps. One study, published in the journal Social and Personality Psychology Compass in 2011, found that people who have supportive, close relationships have lower levels of systemic inflammation compared to those people who have cold, unsupportive, and conflict-ridden relationships. Some studies show that mindfulness-based practices like yoga and meditation can reduce stress. Being mindful means you accept each moment as it is without judgment. Seeing something as neither good or bad, it just is. And it's really hard to do. It definitely takes some training, but it's worth it. One study published in the Annals of Behavioral Medicine reaffirmed previous studies that mindfulness decreases distress and increases quality of life. So do some yoga, take a breath, everything is gonna be A-okay. What are you most stressed about? How do you deal with it? Let us know in the comments below. And while you're at it, hit those like and subscribe buttons and keep coming back here. We've got new episodes every day.
Okay. So stress definitely takes its toll on our body and can cause a lot of adverse side effects. Let me get back to my slide. There we go. All right, so some type of individual types of trauma or stressors that we can see in some of our patients. They may have a history of abuse, so child abuse. It could just be domestic violence when you're older and you're married or you're in a relationship with someone. It could be from a major illness for themselves. Maybe they were in a horrific car accident and they were hospitalized for months. Maybe something happened to a close family member. Maybe someone in their family died all of a sudden. They could be a victim of crime, some type of robbery. When we think about, so those are your individual traumas or your stressors. When we think about group trauma, we're talking, so these are traumas that can affect more than one person. So our military personnel that go away to war, when we have natural disasters and they affect an entire community of people, and then any type of community loss. So you're thinking of like the death of a prominent citizen. So some of our patients will present with certain characteristics. So they will probably have poor coping skills. They will always seem frazzled, and they will always be stressed out. They will not be able to handle their stress effectively. They might report to you that they're always just running on fumes. They're always stressed out and they're barely hanging on. They're going to have emotional difficulties, difficulties resuming activities of daily life. So simple things, just like getting up every day and getting dressed, going to the grocery store, making dinner, cleaning the house, taking to the kids where they need to be, all of their activities of daily life. They also may present with anxiety. They will report not being able to sleep, and they may also have prominent signs of grief. So some psychiatric problems that can be treated that are related to this trauma or significant stress can be an adjustment disorder. They might even start to be depressed. Could just be the beginning stages, or it could be to the point where they need to have some inpatient treatment or where they're contemplating suicide. They could have complicated grieving, which is where they're always, grief is like a process. It starts off at some point and then it goes through various different stages. But when we talk about complicated grieving, they always stay like in this worst stage where they're not they're not progressing along. They're just kind of stuck in that state. We could have an acute.
I'm sorry. Can you let Tezra in, please?
Yes. An acute stress disorder, they can also get post-traumatic stress disorder, PTSD. We're going to talk about that, and then dissociative disorder. So adjustment disorder, this is when a stressor triggers a reaction in your body, causing changes in your mood, and or it causes some type of dysfunction in your ability or the patient's ability to perform their usual activities. So just their activities of everyday life, some of the things that we just mentioned. So risk factors for developing this would be a pattern of lifelong difficulty accepting change. So these people do not accept change at all, no matter how small it is. They usually don't change jobs. They don't move from their homes. They don't buy new cars. They have a very hard time with any type of change at all. It's a learned pattern of difficulty with social skills or coping strategies, which when a stressor occurs can trigger a stress response that is out of proportion to the stressor. So the response that you see is not necessarily just because of that stressor. It's kind of like it's been this built up situation. And then they finally explode when they actually deal with just this minute stress in their life. So signs and symptoms would be depression. They could also have anxiety. They can see changes in their behavior, such as arguing with others or driving erratically. They just fly off the handle for no reason at all. They have a very short fuse. Then we have acute stress disorder. So this is exposure to traumatic events that cause anxiety, detachment, and other manifestations about the event for at least 3 days, but not more than a month. And then our post-traumatic stress disorder is exposure to a traumatic event, which causes the same signs and symptoms, anxiety, detachment, and other manifestations, but the event will last for longer than a month, and it can even last up to a couple years, 3 or 4 years or longer. So when we compare acute stress disorder versus PTSD, acute stress disorder occurs after a traumatic event and is characterized by re-experiencing. So this is where they're thinking about it in their mind. They're thinking about this experience. They're avoiding certain things surrounded by the experience, and then hyperarousal. When we see this, it's usually that an event occurred within the last 3 months. And it can also be a precursor to PTSD. So if it's not really taken care of or they stay in this state, it's eventually going to turn into PTSD. So PTSD is usually something we see in patients that have experienced a traumatic event that at least 3 months, more than 3 months ago. So it's been longer than 3 months. PTSD is very chronic in nature. They can have periods of exacerbations where they're doing really well and they feel like they don't have it anymore. And then it can come back very quickly without any warning at all. And they can be very debilitating because it's mentally draining for them because they feel like they're in a better place. But then when these issues start coming back again, it kind of catches them off guard. So it's very draining. And PTSD can lead to other psychiatric disorders such as depression, anxiety, and substance abuse. So these patients don't, some of them don't have good coping skills, or because they keep reliving it or dealing with it, they can't make any progress towards getting better. So it causes them to become depressed. It causes them to be anxious because they live in fear that they're going to constantly be reliving or thinking about this traumatic event. And then for those patients who don't have good coping skills, they don't want to live in that state all the time and they don't want to think about the things that happened. So they self-medicate with alcohol or obviously with drugs. So PTSD does occur in about 25% of survivors of physical assault. 70% of survivors of rape develop PTSD. It can occur in children. It can occur in adults and older adults. Let's see. Well, I don't know why this one's not working. Oh, well, this one's not working for some reason. Okay. So adolescents are more likely to develop PTSD than children or adults. There is an increased incident that is going to be related to your age, your gender, the type of trauma that you are subjected to, and whether or not you have repeated trauma after that. Adolescents with PTSD are at an increased risk for suicide more than any other age group. They're at a high risk for developing substance abuse, developing poor social support, poor social networks. They suffer from academic problems, and they are more at risk for poor physical health as well. PTSD is capable of disrupting the biologic maturation processes, which can contribute to these longer-term emotional issues that we see and some behavioral issues. So there can be predictors of PTSD, so risk factors. So in order for you to develop PTSD, there has to be some type of major trauma, some type of event that occurred in the person's life that's going to cause them to develop this. They have to directly be involved in the traumatic event. So it has to happen to them, or it has to be a very close family member. Like if one of their family members was killed violently, or they lost a child, they have to be directly involved. Sometimes there are experiences of physical injury. So patients that have been in car accidents, these natural disasters, and they've had these, terrible stories about how their house got blown away, or like I said, a loss of a loved one. Lack of social support. So having family and friends to rely on and talk to. Someone was just trying to get in, but I don't know who it was. Now they're gone. If they text you, just let me know and I'll let them in. So lack of social support, peri-trauma disassociation, having a previous psychiatric history, or personality disorders can further increase the risk of that person developing PTSD when there is present pre-trauma. All right, so there's four subcategories of symptoms in PTSD. So patients with PTSD can re-experience the trauma that they initially experienced several ways. So through dreams, so they can dream about it at night. When they go to bed at night, if they take naps, just even sleeping for 45 minutes to an hour, they can dream about it. or they can just have these recurrent, what they call intrusive thoughts that just keep popping into their mind. Even though they don't want to think about it, it just keeps coming and replaying in their mind over and over again. They might start avoiding things in their life. They might not even realize that they are avoiding it. They might avoid things that are related to that situation somehow. So if something traumatic happened at a certain area, at a certain part of town, they might avoid that area. They might avoid people that were also, included in this traumatic event, and they don't even realize they're doing it. They can have negative cognition or negative thoughts. And then they also can have hyperarousal, which is where they're always being on guard, they're always on edge, they're always irritable, they're very, very tense. The person persistently re-experiences the trauma through their memories, those dreams. They can have flashbacks, which are extremely vivid. It actually makes them feel like they're there and they're experiencing it. They can have reactions to external cues about the event. And then, like I said, they avoid stimuli associated with that trauma. So you guys should look at box 13.2, which is on page 207 at that PTSD checklist. And then you can also look on page 209. You can see that DSM-5 diagnostic criteria for post-traumatic stress disorder. All right, let's see what this one is.
Wherever today takes you, whatever tomorrow demands of you, you'll be prepared. Because for more than half a century, Walden University has been preparing for you. Individuals with PTSD may lose interest not only in the things that they used to enjoy doing, but with life as a whole. They can also be violent, either verbally or even physically at times. Anniversaries of the traumatic incident can be unnerving, and anything that reminds sufferers of their terrifying experience may cause them to suffer from bad dreams and nightmares. Seemingly simple things in ordinary occurrences may give them sudden flashbacks, such as a sound or smell, or watching a movie. These little things will make them lose touch with the present and make them feel that the traumatic incident that happened to them is happening once again. For a person with PTSD, it is like experiencing one of their nightmares while being wide awake. Not every person who experiences a traumatic event will develop PTSD. However, some people do suffer from severe PTSD because of the trauma, while others will only have mild PTSD or anxiety. The symptoms often start to manifest within the first 3 months from the date of the incident. A person is only diagnosed with this condition when found to be suffering from its symptoms for more than a month. Some individuals are able to recover after 6 months, while others suffer from it for more than a year. For cases of chronic PTSD, studies show that women are more prone to have PTSD than men. However, age is not a factor. This condition can affect men and women regardless of their stage of life. If PTSD is suspected or symptoms are being exhibited, expert psychological help should be sought early to assist in preventing the condition from doing further damage to both the sufferer and their loved ones.
If you suffer from anxiety or panic attacks, then click here to get your completely free guide to overcoming and beating.
Okay. Okay. So some trauma, stress-induced disturbed patterns of behavior that we might see. They might say that they feel numb to certain situations, that they don't feel like they have, that they can participate in certain relationships with their friends, with work. They feel like they're just barely hanging on. Like I said, they can experience trouble sleeping at night, mainly because they're afraid that they're going to dream about what happened, and it's always in their mind, so they're afraid to sleep. That hyperarousal or hypervigilance, where they're always on guard, always on edge. They can be irritable. They can have angry outbursts. They report that loss of a sense of connection with their loved ones, with their friends, with the outside world, and they feel like they are losing control over their life. They don't really feel like they have control over anything. All of these behaviors can lead to avoidance behavior, or trying to avoid any places or people or situations that they think are going to trigger them to have to relive that situation again. And like I said, they might not even be aware that they're doing it. They seek comfort, they want to feel safe, and they want to feel secure because they don't feel like that right now. They feel extremely vulnerable because no matter where they go, all these thoughts are always in their mind and they can't get away from it. So that's why it becomes so overwhelming. And then it can be they can become very isolated over time because they're scared. And that being isolated like that and having even more time to think can heighten the negative feelings that they have and encourage that thought process, which they're trying to avoid, which really makes things worse. All right, so what can we do to treat these patients that have PTSD? So psychotherapy obviously is a great help. It can be in individual or in group. It just depends on how severe the patient is and if group is something that they're ready for. 9 times out of 10, unless they are so severely depressed and they're suicidal, it's going to be in that outpatient setting. Remember, those inpatient settings are really for those crisis situations. And then during those times of severe crisis, then yes, they might have a short inpatient stay to kind of get their head above the water, get them on some medication, get them a little feeling better, and then we'll put them back into the community and start that therapy on an outpatient. So depending on the patient, what they have, what their symptoms are, maybe they're depressed and they need some antidepressants, we can get them prescribed for the patients, some anxiolytics, something to help them calm down, some Ativan, Haldol, and then some sleep aids. So something that's going to help them sleep at night. So it's the combination of, not being able to sleep because they're so overwhelmed about having these thoughts, but then night after night after night of not being able to sleep, then that takes a physical and mental toll on you as well. And not sleeping, actually, if you lose enough sleep over a certain amount of time, it can cause you to die. You can actually die from not having enough sleep. So it's kind of like this vicious circle. So giving them something to help them sleep at night will actually really help them a lot, mentally and physically. Usually a combination of both therapies, so that medication component and that outpatient individual or group treatment together always produces the best results. There's always self-help groups. If they're ready and they're willing to do that and they feel okay doing it on their own, they can partake in that. There's something called exposure therapy, which is designed to help the patient combat that feeling of always wanting to avoid certain things related to that trauma. This can be a very hard thing for patients to do because they are really forced to deal with their emotions and their trauma and those stressors head on. Rather than having them avoid them all the time. So it takes them out of their comfort zone. They really have to kind of deal with this trauma one-on-one. And some patients, are not in that spot ready to do that yet, or they just don't want to do it because they know how hard it's going to be. Relaxation techniques. So these can be used to help the patient try to relax when they feel themselves getting on edge, when they feel themselves getting into that hyperarousal state or that hypervigilance state. At night when they can't sleep, it can help them try to relax, to get some sleep. Then they have adaptive disclosure, which was this was developed by the military. It offers intent-specific short-term therapy for active duty military personnel. It incorporates a component of that exposure therapy, as well as something called the empty chair technique. And the empty chair technique is where the participant says whatever he or she wants or needs to say to anyone, whether it's someone that is alive or it's someone that has passed on. Cognitive processing therapy. So this is something that's very successful for patients who have been victims of rape that have developed PTSD. We also see it used with our veterans. It involves very structured sessions that focus on looking at the beliefs whether they're appropriate or not, that are interfering with them being able to just carry out their regular activities of daily living. So what's actually causing you to do that? Do you feel guilt? Do you feel blame? Usually what they're feeling is very misplaced, and it's not really how it actually seems. So that's what the cognitive processing therapy kind of talks about. So nursing care for patients with PTSD. So one of the most important things that we can do is establish that therapeutic relationship and encourage the client to share their feelings. So some of these patients, they don't feel like they can trust anyone, or they don't feel like they can feel comfortable talking to someone. And sometimes they just don't want to talk about it again. So if you really work hard to establish that therapeutic relationship with them, be truthful with them, be consistent, come when you say you're going to follow up on things that you promise to do to them, you'll build that good trusting relationship, and they'll know that they can open up to you. Provide a very safe, non-threatening, routine environment. Make sure you're assessing them for suicidal ideation, especially if they have that depression associated with the PTSD, and then obviously take any precautions as necessary. You can use other strategies to decrease anxiety besides the medication. So you can offer music therapy. There's guided imagery where they can look at different pictures of vacation spots, puppies, animals, whatever they like to look at. Massage therapy, and we can also do certain breathing techniques with them. All right, so some of the nursing diagnoses that we might see for PTSD: anxiety, of course, related to exposure to internal or external cues that symbolize or resemble an aspect of that traumatic event that they had. Chronic sorrow related to chronic disability, physical or mental. Death anxiety related to psychological stress associated with that traumatic event. Ineffective coping related to extreme anxiety. Ineffective impulse control related to thinking of initial trauma experience. Insomnia related to recurring nightmares. Post-trauma syndrome related to exposure to a traumatic event. Sleep deprivation related to nightmares, interrupting sleep associated with traumatic event. Risk for powerlessness. Risk factors, flashbacks, reliving the event. Risk for self or other directed violence. Risk factors, fear of self or other people. And then readiness for enhanced comfort, so expresses a desire to enhance relaxation. And readiness for enhanced communication, a willingness to express feelings and thoughts. So our treatment outcomes for clients who have survived trauma or abuse may include: the client will be physically safe. These patients are usually at a high risk of committing suicide and committing self-harm, depending on how long they've had the PTSD. So the client, that's one of our main priorities, is we want them to be physically safe. We don't want them to harm themselves. The client will distinguish between ideas of self-harm and taking action on those ideas, two different things. The client will demonstrate healthy, effective ways of dealing with stress. The client will express emotions non-destructively, and the client will establish a social support system in the community. So dissociative disorder. So this is characterized by a disruption in the integration of consciousness, their memory, their identity, and their environmental perception. So people with dissociative disorders use disassociation, which is a defense mechanism, pathologically and sometimes involuntarily. Dissociative disorder leads to disturbances in relationships. So at the job, between friends, parents, loved ones, family members, relationships through all aspects of their life. It also affects their ability to function, again, so being able to carry out those activities of daily living, and the ability to be able to cope with what's going on in their life. People with PTSD often experience dissociative symptoms. Disassociation is a subconscious defense mechanism that helps people protect themselves from emotional harm, from recognizing the full effects of some horrific or traumatic event by allowing the mind to forget or remove itself from the painful situation or the memory. So they're completely disassociating themselves from that situation. It's a defense mechanism, and it is subconscious. They don't even realize that they're doing it. So we can see people exhibit disassociation during the event as it's happening, and then after it's occurred. And every time they do that, it becomes, even though they're not aware they're doing it, it becomes easier for them to do it again, and it becomes a continual cycle. I don't understand. Some of these work and some of them don't. I don't know why. Huh. Oh.
I won't grow up. I won't grow up. I don't want to go to school. I don't want.
Put up the definition of dissociative identity disorder. And you, of course, know this because you've been dealing with it a long time, but it's a severe form of dissociation, and it's characterized by identity division. And that's rather than a creation of separate personalities. So individuals also experience recurrent, extensive episodes of memory loss. It's not explained by just forgetfulness. So this is not to be confused with split personality or multiple personalities. What it is the individual identity. There's one identity, but it's fragmented into different parts. And what happens is necessity is the mother of invention. You've heard that old saying, right? If you get in a situation where the stress is overwhelming your coping skills, then you will escape that situation by leaving that part of your identity and just going to another part of your identity. You vacate that awareness. You often see it if somebody's been in a terrible accident or something. They'll have no memory of it whatsoever. And you ask them about it, see, I know I was in an accident, but I don't remember it. And you might know that they saw a loved one killed or something, but they'll say, I don't remember it. They have that memory loss. And sometimes if that trauma is recurrent, this is too painful, this is too stressful, so I just vacate my consciousness and go somewhere else. And when that stops, then I'll come back. And what I'm saying is that's what's at the core of almost every dissociative identity disorder that I've ever encountered. I think it's at the core with you, and I don't think that it's ever going to change unless a couple of things happen, and I'm going to tell you what I think those things are, because I want to help you with it, okay?
Okay, good old Dr. Phil. All right. So that was actually a good explanation. So I'm glad that video worked. All right. So there are a couple different types of dissociative disorders. So there's dissociative amnesia. So the client cannot remember important personal information, usually surrounding that traumatic event or stressful event. Signs and symptoms would be that obviously they have a lack of memory that can range from name or date of birth of the client's entire lifetime. We have dissociative fugu, a type of dissociative amnesia in which the client travels to a new area and is unable to remember one's identity and at least some of or part of their past. This can last weeks after this traumatic event and usually obviously follows a traumatic event. We have dissociative identity disorder. This was actually called at one time multiple personality disorder. They don't call it that anymore. Client is going to display 2 or more distinct identities or personality states that recurrently take control of his or her behavior. This is accompanied by the inability to recall important personal information. And then we have depersonalization, derealization disorder. So this is where the client has a persistent or recurrent feeling of being detached from his or her mental processes or body, depersonalization, or sensation of being in a dreamlike state in which the environment seems foggy or unreal. That's what we call derealization. And then the client is not psychotic nor out of touch with reality, but instead they are kind of like detached or kind of like in a fog. So these are more prevalent among patients who we see that have a history of childhood physical and sexual abuse. So there's a couple different videos there if you guys want to watch them. So therapy for dissociative disorder is going to focus on reassociating them, something they don't want to do. They're completely dissociating themselves away from that issue. So it's going to be very hard for them. It's why it's hard for them to seek treatment. They don't want to deal with it. And it's hard for them to stick with it because they don't want to have to constantly deal with that traumatic issue again. So it focuses on reassociation and putting the consciousness of their life back together instead of pushing things to the back of their mind and avoiding them. The goals of therapy are to improve their quality of life. We want them to have a better quality of life. We want them to carry out their activities of daily living, go to work every day, be successful at work, be able to pay your bills because you can keep a job, have good, meaningful relationships with friends and family members. So improved quality of life, improved functional abilities, being able to drive yourself around, manage a budget, cook, clean, and then reduce those symptoms that you're seeing. So anxiety, insomnia, things like that. So there's individual therapy, there's hypnotic therapy that you can go to where they hypnose you, and then supposedly they hypnotize you, and then when you come out, supposedly you don't deal with those issues anymore, or if you do have the issues, they're not as bad as they were before. There's group therapy where you would obviously be in a group with other people with the same issues. And the main focus of group therapy is that reassociation. We could give medications, antidepressants, if there's a depression component to it, and then those anxiolytics to help calm them down and help with the anxiety. Medications might not be prescribed unless there are specific findings of that depression or anxiety, because we would just be treating the symptoms, not that dissociative disorder itself. So when we are performing an assessment on our patients that have had some type of traumatic or stress or event, our focus is going to be, of the nurse, is going to be to look at the history. So we want to try and determine, was there a traumatic event? Because in order for them to have these issues and to have it be a traumatic or a stressful event, there has to be an event. So a history of events. Did something happen when they were a child? Did something happen recently? We want to try and figure out when it occurred. So did it occur just recently? Did it happen when they were a child? Observation of the patient's appearance and motor behavior, especially we're going to be looking for that hypervigilance. Being on that hyper alert where they're, right on edge all the time and they're really cranky and irritable. Do they feel anxious? Are they restless? Can they not sit in their chair? Are they constantly walking around? Are they talking really fast? Are they pacing back and forth? Are they, wringing their hands together while they're talking? Increased personal space. So do they need to be far away from you? Do they not feel safe around you? So they need to put more distance between you and them. And sometimes we might even find these patients in the fetal position, sitting on the floor, rocking themselves far away from other people. And we want to look at their mood and their affect. So obviously, depending on what type of traumatic event it is and how much trauma they're dealing with, that could just range to, they could be very passive, or they could be very hypervigilant. They could be very angry. They could be very scared, agitated. They could even be hostile. So it just depends. But those are the things you would want to look for. Their thought process and their content. So are they experiencing nightmares? Are they having flashbacks? Are they having flashbacks when they're with you? That can be scary if they're actually reliving a flashback because they feel like they're in real time dealing with that. So your priority is going to try to be to just watch them and keep them safe. Are they having intrusive thoughts? Are they having trouble, with their therapy, their one-on-one sessions, because these thoughts just come through their mind and they can't stay on topic? Maybe they're having hallucinations. And then we want to make sure that they're not having any self-destructive thoughts or fantasies, because we want the client to be safe. We don't want them to commit suicide or anything like that. So we really have to assess for those. Sensorium and intellectual processes. So we're going to be looking to see if the patient has any issues with memory. So if you're talking to them about when this traumatic event occurred and they say, I think it happened when I was 8 years old. So then you start talking about things before 8 and then things after 8. And if they don't have a recollection of these large periods of time before or after, then they've got some type of a memory gap. And are they engaging in poor decision making? If they don't have good coping skills, they might be making poor decisions. So, over drinking, deciding to use drugs, not going to work, not paying their bills. And then roles in relationships. So are they having problems at work? Are they not going to work? Are they having problems with their family relationships, their parents, their loved ones, their children? Are they getting in trouble with the police? Things like that. So these are some of the nursing diagnoses we might see. So risk for suicide or self-mutilation, ineffective coping related to personal vulnerability in crises of accurate self-perception, post-trauma syndrome, powerlessness. A lot of these patients feel powerless because they don't have control over the thoughts that they have. Chronic low self-esteem, risk for self or other directed violence, disturbed personal identity related to inability to distinguish self caused by multiple personality disorder, depersonalization or disturbance in memory, impaired memory related to altered state of consciousness, anxiety related to psychosocial stress, fear, disturbed sensory perception, sleep deprivation, disturbed sleep pattern, sexual dysfunction, spiritual distress, and social isolation. So nursing care for dealing with these patients so we can help the clients make decisions in their life that are going to lower their stress. So what kind of things do they might feel like they don't have a lot of control over anything. So we can kind of sit back and talk to them about what things they do have control over, what things can they control. With this particular group of people, you want to make sure that you avoid touching them unless you have permission, because especially if they're in that hypervigilant state, or if they're having some type of flashback, it can cause them to become more hostile, especially if they don't have that trusting relationship with you. So that's a big one. When the client shows readiness, encourage their independence and their decision making. So if you've been meeting every week for months and, maybe they haven't been working, but they feel stable enough now and they've been making the right decisions, encourage them to go back to work, take control of their finances again, little things when they're showing that they're ready to do that. Instruct clients in strategies to help reduce their anxiety. So any kind of guided imagery, taking deep breaths, removing yourself from the situation, counting to 10, putting on your favorite song, thinking about your favorite place at the beach, different types of things. Allow clients to verbalize negative feelings in a safe manner. So we always want them to feel safe and that we're not judging them, and we want them to be able to talk about their feelings, even if they're negative, but we always want them to do it while they're not having like a destructive behavior. It has to be in a safe environment. And you want them to go at their own pace. So you want to ask about things to use those open-ended questions to get them to talk about more, but we want to respect them if they stop and they don't want to talk anymore about certain things. Avoid giving the client too much information about past events to prevent increased stress. So if you're working through some type of a traumatic event that you know more about than the patient does, then you probably don't want to give them too much information that you cause them to become more anxious and more on edge. So you kind of want to let things go, take their toll, and continue to work with the patient week by week until he's able to realize that information. And then that focus is to improve the patient's self-esteem, and we want to promote empowerment. So we want them to take control of their life. We want them to be productive members of society. We want them to go back to work and be a great employee and be a good family member and show up for their friends and their family members. We want to refer to the patient as a survivor rather than a victim, because we don't want to encourage them to always be in that role of the victim. We want to empower them that they've survived this, that they are surviving this, and that it doesn't define them. We want to be able to really work hard to identify what their flashback triggers are. So if we can identify what triggers them, then we can avoid them. If they can avoid their flashbacks, then they're going to make progress. They're going to feel better. Encourage journaling of feelings. This is a great thing. And just encourage them to get a spiral notebook. And when they're feeling anxious or when they're having flashbacks or they don't sleep at night, they can journal. What they did the day before, what was happening when they had the flashback. And then, of course, utilize those distractions and those relaxation techniques. So we can do something with them called grounding techniques. It's very helpful with patients who are having disassociation, or if they're having flashbacks. You remind the person. So if they're having a flashback and you're in the office with them, always you want to keep them safe. You want to talk to them in a very calm manner. Remind them that you're with them, that you're sitting next to them, that you are an adult, that you're here to keep them safe, that you're here to listen to them, that they don't have to be afraid. It's going to help bring them back to reality. It diminishes the dissociative dissociative experience by focusing on the current senses. So some things that are listed there that you can say to the patient. I'm sitting here in the chair next to you. Can you see me? Can you see the room that we're in? Because when they have these flashbacks, they're so real, they feel like they're actually there at that present time. They're really not in the room with therapy. So we're kind of like we do with our dementia patients, we're kind of like reorienting them and trying to bring them back, but in a safe way. And then you can say things like, can you feel the watch on your wrist? Can you feel the chair that you're sitting in? Just anything that would be able to reorient them to their environment. And then, of course, as with everything in nursing, we always have to have self-awareness regarding our issues. So we have to be comfortable asking patients about abuse, trauma, and stress-related issues, which can be very, very hard for some people to do. When people experience traumatic events, they're traumatic, and they can also be traumatic for you. So it can be hard to listen to stories of abuse all the time and trauma and other people's stress. So you need to be aware of that. Listening to accounts of trauma from patients and families, recognizing their patient's strengths, not just their problems. So sometimes I feel like because we focus on so many problems all the time, that's the way that we think. With mental health, we really want to try and focus on their strengths as well. Dealing with our own feelings about traumatic events, abuse, and natural disasters. If we have ever been involved in any of those situations, we really need to look at ourselves. And then always, we want to work hard to make sure that we're maintaining confidentiality with our patients. All right, so that was it. Any questions on trauma and stress before we go to personality disorders?
Are those grounding techniques only for dissociative disorders, or could that work for PTSD and everything else as well?
I mean, if they're having flashbacks and things like that, then you could. It would be appropriate.
Okay.
Thanks. Yep. All right. All right, personality disorders. So the objectives are to describe personality disorders in the terms of the client's difficulty in perceiving, relating to, and thinking about self, others, and the environment. Discuss factors thought to influence the development of personality disorders. Apply the nursing process in the care of clients with personality disorders. Provide education to clients, families, and community members to increase their knowledge and understanding of personality disorders. Evaluate personal feelings, attitudes, and responses to clients with personality disorders. So we are going to talk about aggression, abuse, and violence, addiction, personality disorders. I don't know why. Sometimes it works and sometimes it doesn't. I don't get it. Click.
Let me see it. Let me see your book.
Please leave me alone, Miss Kenton.
Why won't you show me your book?
This is my private time. You're invading it.
Oh, is that so?
Yes.
I'm invading your private time, am I?
Yes. Yes. I read these books. Any books. To develop my command and knowledge of the English language. I read to further my education, Miss Kenton. I really must ask you, please, not to disturb the few moments I have to myself.
shitheel. I'm standing here. You make the move. You make the move. It's your move. I'm trying you. You talking to me? You talking to me? You talking to me? Well, then who the hell else are you talking? Talking to me? Well, I'm the only one here.
I'm sorry, but we don't usually let strangers in.
Right, Pete, check the rest of the house. 10. I'm singing in the rain, just singing in the rain. What a glorious feeling. I'm happy again. I'm laughing at clouds so dark up above. I'm going.
Why don't you come over here and say goodbye nicely? Let's be friends.
Baby, no. It's okay. It's okay.
I'm sorry if I upset you.
It's okay. It's okay, really. It's okay. All right, that's okay. It's open. No, come here. Hold on.
Oh my God, I love your skirt. Where did you get it?
It was my mom's in the 80s.
Vintage. So adorable.
Thanks.
That is the ugliest effing skirt I've ever seen. Oh my God, I love your bracelet. Where did you get it?
So are you gonna send any candy canes?
No, I don't send them, I just get them. So you better send me one, biatch. Love ya.
From your words, as Mr. Emmons quotes them in this book, it's clear that you were guilty of murder, and yet he says in all his conversations with you, he never heard you express remorse. Have you never felt it?
Remorse for what? You people have done everything in the world to me. Doesn't that give me equal right? I can do anything I want to you people at any time I want to, because that's what you've done to me. I'm 10 times the Pope. I'm 50 times the Pope. But I'm the Pope in the hills and in the mountains. I'm already out of here. This enclosure here, I'm out of here.
My leg hurts. I wonder if it's cancer. There's a bump. I'm starting to sweat. Stop sweating. I've got to stop sweating. Can she see it dripping down my forehead? Oh, she looked at my hairline. She thinks I'm bald.
We think you're great.
Oh, wow. Thanks. That's nice to hear.
We all just loved the Malkovich script.
Thanks.
Such a unique voice. Boy, I'd love to find a portal into your brain.
Trust me, it's no fun.
Vacation? Oh, certainly. My secretary told you. As of this afternoon, I'm taking my family on vacation until Labor Day.
Yes, this is Bob Wiley. I'm a patient of Dr. Marvin's. I have to speak with him right away. It's urgent.
I'm sorry, Mr. Wiley, but Dr. Marvin's
It's
out of...
Bob. And you are?
Betty.
Betty, hi.
Bob, Dr. Marvin's out of town and Dr. Harmon's taking his calls.
I know that, Betty. But you could call him on the other line and tell him that I'm on hold on the other line. Couldn't you, please?
This is Dr. Marvin. What's the problem, Bob?
Dr. Marvin, how's the weather up there?
What?
How's your brood? You all getting a chance to relax?
Bob, I thought I made it clear to you that I'm on vacation.
Well, I know, but I'm just worse than usual this time, really bad.
Bob, if this is really an emergency, go to the emergency room. And if it isn't, call Dr. Harmon. I'm sure he can help you.
Well, I'd just feel so much better if I knew where you were. It's Martha's Vineyard, right?
Bob.
Well, can't we just talk?
Yes, we can. In my office, after Labor Day.
After you're back from Fire Island, huh?
Goodbye, Bob.
What, you want to keep Maine all to yourself?
Goodbye, Bob.
Is this a fake hang-up? It's a fake hang-up. Dr. Marvin! Dr. Leo Marvin! Dr. Marvin! Dr.
Right over there.
Dr. Leo Marvin!
Oh, my God.
Dr. Marvin! Oh, I really...
Hey, what happened to the apartment? It's been given the good housekeeping seal of approval. Deal with cards.
Hey, I'm all right, Annie.
Annie,
What?
what? Everybody in?
What?
What are you playing?
Cold glass of beer for Roy.
Thank you.
Where's your coaster?
My what?
The coaster, a little round thing that goes under the glass.
I think I bet it. Here. I knew I was winning too much. Here.
Always try to use the coasters, huh, fellas? Scotch, a little bit of water.
Scotch and a little bit of water, and I have my coaster.
I don't want to be a pest, but you know what white glasses do.
They leave little rings on the table.
Little rings on the table.
And we don't want little rings on the table.
And we have a nice, warm sandwich for Vinny.
Ah, gee, it smells good. What is it?
Bacon, lettuce, and tomato with mayonnaise on pumpernickel toast.
You mean you just made it?
1, 2, 3.
You put in toast and cooked bacon just for me?
Don't like it? It'll make you meatloaf. Takes them 5 minutes.
You know I love to eat over the dish. I just vacuumed the rug.
Good.
Hey, Oscar, what did you want?
2 3.5-minute eggs and some petit fours.
Wait, oh, double gin and tonic, right? With the Who turned off the dehumidifier?
What?
The dehumidifier. Fellas, I asked you, don't play with this thing, huh? I'm trying to get some of the grime out of the air.
Okay. So I thought that was actually pretty interesting. I know it was a little longer, but it does kind of give you the an idea of what those different types of personalities look like. All right, so there are many different types of personality disorders. So this is a nice little cheat sheet that's on your slides. I'm not going to read all of these, but it does go over a lot of those personalities that we saw in the movies. So what is our personality? So basically, our personality is an ingrained, enduring pattern of behaving and relating to ourselves, others, and the environment in which we live. It includes how we perceive things to be, how we understand things, what our attitudes are towards different things, and what things we feel as emotions. These behaviors and characteristics are consistent across a broad range of situations and are not easily changed. That's the big thing I want you to understand, that it is not easy to change someone's personality. Many factors influence our personality. So we have our biologic and our genetic makeup, how we were born, and then some of the factors we acquire as we start to develop and we interact with our environment and our people. So when we were born, when we were little, who our babysitters were, when we went to school, who our friends were. As we went into the workforce and we went to college, who were our friends? What were our parents like? Did we have siblings? Our entire environment has a huge input to the development of our personality. So personalities will occur when there is an impairment of personality functioning and personality traits that are considered maladaptive. Individuals have identity problems are labeled as egocentric. They are can be labeled as being self-centered, and their sense of self-esteem comes from gaining power. They have to be in control, or pleasure that is often at the expense of other people, family members, friends, employees. Their behavior fails to conform to to cultural, social, and legal norms. They're motivated by personal gratification. Relationships with others are usually considered dysfunctional and stressful. They're often characterized by not a lot of trust, deceit, coercion. They intimidate a lot of people that they're around. They're not capable of having a mutual, functional, healthy, intimate relationship, and they usually lack the capacity for practicing empathy, remorse, and general concern for others. Not usually diagnosed until they're adults, because when they're children, we just contribute it to the fact that they're being children, and they're just, children sometimes just, act crazy, and they're growing, and they're, spontaneous, and their brain isn't developed, and their thinking skills aren't developed, and they're good decision makers. Good decision-making capabilities aren't developed. So we kind of like write those things off. But then as they get into being adulthood, then we know that it's really just their personality at this point. And personality disorders are long-standing, again, because those personality characteristics do not change easily. So maladaptive or dysfunctional personality traits can be negative behaviors towards others. They can be manipulative, they can be dishonest, deceitful, or lie, whatever they can to gain personal gratification or satisfaction in their own life, they will do. Manipulation and being dishonest doesn't faze them at all. They could be angry, or be exhibiting hostility. They can be irritable or have those labile moods. When they do things that are not honest, that are deceitful, or if they lie, they don't ever show a lack of guilt or remorse. Some people say that they're very cold-hearted and that they don't care. They can be impulsive, easily distracted, and obviously they have poor judgment. Irresponsible, they're never accountable for their own decisions. So usually these people put blame on everyone else. It's always everyone else's problem but theirs. Risk-taking, thrill-seeking behaviors, mistrust, exhibitionism, a sense of entitlement. They may be deep down inside, they may be insecure. They might not always show it, but deep down they are insecure, and they are very dependent on people, whether they show it or not. And then they have eccentric perceptions. So personality disorder diagnoses are organized according to clusters around a predominant type of behavioral pattern. So we're looking at that behavioral pattern, and that's how we're diagnosing the particular disorder. In most psychiatric settings, nurses usually encounter patients that have antisocial disorders and borderline personality disorders. Those are the two most that we see in the psychiatric setting. Of course, we can see others, but we see these much more often. So we talked about these clusters. So in cluster A, these are what we call odd or eccentric behaviors. So this is that paranoid personality disorder. So you saw in that video of the guy who had 15 locks on his door, and then when he went to the refrigerator, he had 10 locks there, and then his food was locked up in the refrigerator. So if somebody else saw that, that would be definitely considered odd. Schizoid personality, schizotypal personality. We're going to talk about schizophrenia in depth next week. So there will be a lot more to come about that. Cluster B, these are erratic or very dramatic behaviors. So antisocial personality, not really talking to people. Borderline personality disorder, we're going to talk more about that. Histrionic personality disorder and narcissistic personality disorder. And then cluster C would be anxious or fearful behavior. So this is avoidant behavior disorder, dependent personality disorder, or obsessive personality disorder. So other clusters of behaviors related to maladaptive personality traits also include depressive behavior and passive aggressive behavior. Your book doesn't go into a lot of detail about them, but they do mention them. So personality disorders are relatively common, more common than we would probably realize. We probably know people that have personality disorders and we just haven't picked up on it. It occurs in 10 to 20% of the general population. The incidence of having or developing a personality disorder is even higher for people in lower socioeconomic groups and unstable or disadvantaged populations. Psychiatric inpatients, people that are inpatient, 15% have a primary diagnosis of a personality disorder. Those having a primary diagnosis of major mental illness, 40 to 45% of them also have a coexisting personality disorder that significantly complicates their treatment. In mental health outpatient settings, the incidence of personality disorder is about 30 to 50%. So in our community. They have, these patients that have personality disorders have a much higher death rate because of suicide. There are higher rates of suicide attempts, accidents, and emergency department visits. So when we think about accidents, we're talking about that risk-taking behavior that we said that they would have a couple slides back. There are increased rates of separation, divorce, and involvement of legal proceedings regarding child custody. Personality disorders have been highly correlated with criminal behaviorism, criminal behavior, alcoholism, and drug abuse, which kind of makes sense if you think about the things that we talked about a couple slides back. You know, you don't really have, you always want to be in charge. You don't really recognize authority. You participate in risk-taking behaviors. Well, eventually that's going to get you into trouble. Personality disorders are often described as treatment resistant. Why? Because it's so hard to change someone's personality. Characteristics and behavioral patterns are deeply ingrained. And there you have it. It is very difficult to change one's personality. You guys need to remember that. Oops. All right, so biologic theories. So biologic theories believe that personality is going to develop through the interaction of, there's a hereditary component, and then also our environmental influences. So whatever's passed down from our mom and our dad, how their personality is, and then also how we were raised, who our friends were, what type of environment we grew up in. Temperament traits, there can be harm avoidance, novelty-seeking behaviors, reward dependence, and persistence. They believe that each of these 4 genetically influenced traits affect a person's automatic response to certain situations. These response patterns are ingrained, usually they say by the age 2 or 3 years old. There is high harm avoidance and low harm avoidance. So high harm avoidance is where you exhibit fear of uncertainty, social inhibition, very, very shy around strangers, and pessimistic worry in anticipation of certain problems. So these are people who want to avoid harm at all costs, and they're always on alert for harmful situations. Behaviors may result in maladaptive inhibition and excessive anxiety because they're always worrying. They're always thinking about what could happen, what could go wrong. Then there's people who have low harm avoidance. So they're very carefree, they're very energetic, they're outgoing, they're optimistic, they don't have a lot of stress because they're not worrying about what can go wrong and what's going to happen. But this may result in unwarranted optimism and unresponsive to potential harm or danger. So the opposite of that is something could potentially happen to them because they really aren't trying to avoid certain things. So probably having a perfect mixture of both would make a healthy person. So we have psychodynamic theories where they believe that temperament is largely inherited. So more so than what our environment exposes us to. Temperament is most of our development of our personality. Character consists of concepts about ourselves and our external world, develops over time as a person comes in contact with people and situations and as they confront challenges. Three major character traits have been distinguished with these psychodynamic theories. So that's self-directedness, cooperativeness, and self-transcendence. This theory believes that when fully developed, these character traits define a very mature personality. So if we talk about self-directedness, this is the degree to which someone is going to be responsible, whether they're going to be reliable, how much information they have, being resourceful, do they have a lot of goals, are they goal-oriented, and any kind of self-confidence that they have. So a person that has high self-directedness, they're going to be extremely goal-oriented. So they're going to have it all planned out. I'm going to get married when I'm 30. I'm going to have 2 kids by the time I'm 33. I'm going to move into my final house by 35. Everything has to be planned out. They're very realistic though, effective, self-confident, and they can adapt to achieve their goals. They want to achieve their goals, they want to make it happen, and they can adapt to anything that comes their way. A low self-directedness would be they feel very helpless. They feel like they can't do anything on their own. They're very blaming. They blame other people for why they don't do well with certain things. They're very irresponsible. They're not accountable for their behavior. They're unreliable. You definitely cannot depend on them. And they cannot set and pursue meaningful goals. They never follow through. Cooperativeness, this is the extent to which a person sees him or herself as an integral part of society. So a patient that has high cooperativeness is going to be empathetic. They're going to be very tolerant, compassionate, supportive, and they're going to live by a certain standard of principles. If they have low cooperativeness, they're going to be very self-absorbed. So they're only going to think about themselves, and they're only going to do things for other people if it benefits them in some way, shape, or form. They're going to be very intolerant of other shortcomings. They're going to be very critical to other people. They're not going to want to help people. They might even be revengeful, opportunistic. So they're just looking for opportunities to better themselves. And then they look out for themselves without regard for the rights and feelings of other people. And then transcendence, this is the extent to which a person considers him or herself to be an integral part of the universe. So high transcendence, they're going to be unpretentious, they're going to be very humble, and they're going to be very fulfilled. They're going to be very helpful when dealing with suffering, illness, or death. And then low self-transcendence is going to be a person that has a lot of issues with being self-confident. So they have very low self-conscious issues. They're going to be very materialistic, controlling, and they have difficulty accepting any type of suffering at all. They don't handle loss of control very well. They always have to maintain control, personal and material losses, and death. This theory believes that the character matures in stages that starts with when you're born, when you're an infant, and it goes all the way through late adulthood. Each stage has an associated developmental task that each person must perform and complete in order for their personality to mature during that stage. Failure to actually maturing and completing that task jeopardizes the person's ability to be able to achieve future developmental tasks. So for example, if the task is basic trust, if it's not achieved when they're in that infant stage, when they're hungry and their diaper is wet and they need to be changed, if no one does that on a regular basis like they should, then mistrust results, and subsequently it's going to interfere with the achievement of their future tasks. When fully developed, these character traits are going to define a mature personality. So we have some cultural considerations. So personality has to always be viewed with consideration of their ethnic background, their social background, and their cultural background, because these things have an extreme, they have a lot of control over the development of their personality. So sometimes we can have a patient that is very guarded or defensive. behavior, maybe it's due to language barriers. So it would be very easy for someone else to perceive this as a very negative thing. They may have different views of avoidant and dependent behaviors, depending on what their culture is and how they were raised and who's the dominant person in the family, who has the right to make decisions, who has to be the one to speak up. If it's not them, then they may seem like they're avoiding situations. If they always let the husband speak, it might seem like they have a very dependent behavior when in fact it's just their cultural background. And then we also have to think about the cultural value of their work and productivity. All right, so treatment is going to be based on what disorder they have, how severe it is, and the amount of distress or functional impairment that they have. So how are they managing their life is what we're going to look at. We can do combinations of medication and group therapy. There's also individual therapy. Usually when we combine the medications with the therapy, that's when we get our best treatment option. Not all people seek treatment. So the patients the disorders where they're less likely to seek treatment, you're going to have that schizotypal, that narcissistic personality, the obsessive compulsive personality disorder. They see issues with other people in these disorders that we just talked about instead of themselves. So it's always someone else that has the problem, not them. That's why they have all these issues. Somebody else is causing these issues to happen. So because they're not accountable, they're not going to seek treatment because they don't think it's a problem with them. And then our treatment, which is important for you guys to know, we want to focus on a change in their behavior. That's what we want, right? We saw these different personality disorders and we saw all the different signs and symptoms and how they present. And we want to change those symptoms that they're presenting with and how they act around others and in society. So our treatment outcomes are going to focus on us actually implementing things in their life that will ultimately change their behavior. So you guys should look at table 18.1, which talks about different drugs that we can use for symptoms of certain personality disorders. And then you should also look at 18.2, because that's also going to talk about appropriate interventions that we would use for personality disorders. So psychopharmacology, so the medications we give, this is going to focus on the client's symptoms rather than a particular subtype of personality disorder. So we look at 4 symptom categories. So we look at cognitive, which is perceptual distortions. We look at affective symptoms and mood dysregulation. We look at aggression and behavioral dysfunction. And then we look at anxiety. So those are the symptom categories that we're going to treat with medication. We know that there can be individual therapy, one-on-one, or group therapy in the community setting. Usually these patients only come again into that inpatient setting for a short time if we're concerned about their safety or we're concerned about them hurting someone else. So goals for clients with personality disorders, we're going to focus on building that nurse-patient therapeutic relationship. We want to build trust with them. We're going to work to teach them basic living skills. So how to show up every day on work for time, at work on time every day, how to be a productive member of society, pay your bills on time, plan a budget, go to the grocery store. We're going to provide support for them. We want to make sure, again, with these group of people that we really focus on their good qualities that they have instead of the bad qualities. We kind of have to even it out. We can talk about the things that aren't so great, but we always want to give them some things that are great, so that they keep coming back to therapy and they keep working on things. We want to work to help control those symptoms that can cause things to feel worse. So when they feel anxious, they're having anxiety, insomnia, can't sleep at night, things like that. And then we want to be able to improve their interpersonal relationship skills with their children, their family members, their friends, their employees, their employers that they work with, other employees. We can teach them relaxation or mediation techniques that can help manage their anxiety. And then there's also something called assertive training. So these groups help people to have more satisfying relationships with other people and to build self-esteem. So some people don't have good self-esteem and they're not very assertive. So if they don't have good self-esteem, they're not assertive about different things, you might see someone that has antisocial disorder that has what I just said, not a lot of self-esteem and they don't feel their assertiveness. So this would be a great group for them to join because it can teach them to feel better about themselves and it can teach them how to be assertive with others in a good way. Some people, like my son, he's 17 and I don't think he has a personality disorder, but he definitely has like some kind of social anxiety. And he always feels like he's not really like good enough to talk to people. He feels like when he talks, he doesn't say the right things. So it causes him to have just a very small group of friends. And it's not easy for him to put himself out there. So these training groups can really teach them how to talk, how to say things in a certain way. It involves group training where they sit with other people and they kind of do like a role play thing where this person tells you this, that, and that, and then you have to respond to them how you feel about it or what do you think would be an appropriate way to speak. So really helps people come out of their shell once they realize that they do have good communication skills and they just needed to fine tune them a little bit or actually use them. Then they start to build that self-esteem. And then once they build self-esteem, then they can start managing all the other aspects of their life. So everything kind of starts to come together. So personality disorders, we can have antisocial, borderline, schizotypal, narcissistic, obsessive compulsive, and avoidant. So when we're doing our assessment, doing that nursing process, so we want to, when we're talking to our patients, we want to try and observe for any type of deceit or any manipulative behaviors. Now, manipulative behaviors, if you were a psych nurse, probably wouldn't be easy for you to recognize as being a new nurse, because I feel like a lot of nurses always try and see the good in people. That's usually the type of people that we are. So it's very easy to be manipulated by this population of people. But after you've been doing it for several years and you've encountered it enough, then you're pretty good at being able to identify it. So you're going to look for that deceit aspect, that manipulation, false emotions. So maybe they're saying that they feel a certain way, but it's just not genuine, not really having any empathy. Patients that have a very narrowed view of the world, usually the center of attention is just on them. Having very poor judgment, making risky decisions, no insight at all, being egocentric, but self-shallow and empty, having relationships with people that only serve their own needs. So this presents as usually they have, issues with everyone in their life. Well, I don't really have any best friends. I used to have Melissa as a best friend, but she did this to me. And then a couple years before that, I was close with Kim, but then, she stopped calling me. And then before that, so as you're talking to them and you're talking about their history, you'll be able to piece together the relationships that they've had in their past and how they've had a problem with all these people. And then they just kind of dispose of these people when they can't serve their needs anymore. A sense of mistrust. So a lot of these people can be paranoid. They think that everybody is out to get them. So they want to do everything for themselves because they don't want to have any kind of open opportunity for anyone to do something for them that there's the potential that they would hurt them. Skillful, they're very skillful and smart at deceiving others. So during the assessment, it helps to check and validate information from other sources. So if you're working in the outpatient center or if you're the inpatient center, it's possible that maybe this person's been there before. And if this is the first time you're seeing them, or you just haven't been doing it for that long, always go to that more experienced nurse and say, this is what he's telling me. I really can't tell if he's genuine. What do you think? Don't ever be afraid to ask someone else or to, validate that information. So then we get to data analysis. So These people usually do not seek treatment on their own. Again, we said because they don't see a problem with their behavior. Their problem lies with everybody else around them. They don't do anything wrong, so there's no reason for them to seek treatment. The only reason that they would is because they perceive some personal gain from doing it. Nursing diagnoses that we might see, ineffective coping, obviously, ineffective role performance, and then risk for other directed violence. Some appropriate outcome identification would be that the client will demonstrate non-destructive ways to express feelings and frustration. The client will identify ways to meet his or her own needs that do not infringe on the right of others. The client will achieve or maintain satisfactory role performance. So as a patient going through therapy, group therapy, individual therapy, or, if they're going to work every day, they're going to be a good employee. And then interventions that we can do. We can provide structure for that therapeutic relationship. We can encourage responsible behavior. So when we encourage responsible behavior, we're practicing limit setting and then confrontation. So when we say confrontation, it's not really, that we're getting in their face and we're confronting them, but we are recognizing the issue and we're talking about it. We're going to help them solve, work with problem solving, and then we want to work of them controlling their emotions. So if we're working on certain things and they get out of control, then they need to leave the room for 5 minutes. They can't come back for 10 minutes, whatever the time is that you set, kind of like a timeout. And then we want to enhance role performance. So we want them to be able to take on the roles of these in these situations where they kind of feel vulnerable or where they feel like they don't have as much control, so that they can work on those issues. So when we're evaluating these patients, if the client can maintain a job with acceptable performance, if they can meet the basic needs for family responsibilities, so managing the checkbook, paying the bills on time, cleaning the house, going to the grocery store, showing up for the functions that the kids have, and if they can avoid committing illegal or immoral acts, then our treatment has been successful. So we want to practice limit setting with these patients. So limit setting is a very effective technique, but you have to do it from the very beginning and you have to be consistent with it. So stating the behavioral limit. So you're going to basically state whatever the acceptable behavior is. John, I don't like it when we're meeting for therapy and we start to talk about issues that bother you and you get up and you start slamming things in the office. Then you want to identify the consequences if the limit is exceeded, and then you want to identify the expected or desired behavior. So Jim, I don't like it when you talk about issues that seem to upset you. I don't like it when you stand up and you start slamming things in the office. That behavior is unacceptable. If you continue to do that, we're not going to be able to meet alone anymore, and you might have to go to another treatment center. What is appropriate is I know that you get upset when you talk about these issues, but you need to stop and think before you do things, before you act in that behavior. What can I do when I start to feel myself getting worked up? I can take a timeout. I can ask for 5 minutes. I can think about my thoughts. So those 3 things are what you have to do. Call them out on the behavior, right? Describe that behavior is unacceptable. Identify the consequence if they do it again, and then identify what you want them to do. So that's what we call limit setting. All right, borderline personality disorder, and then the nursing process application. So when we are doing assessments on patients that have borderline personality disorder, they are going to appear to be unstable in their interpersonal relationships. So with their friends, coworkers, family members, there's always going to be issues. The issues are never going to be them, but there's always going to be issues with everyone. They have issues at home with their mother and their father. They don't get along with their kids. Their best friend is fighting with them. They have issues at work, everywhere across their lifespan. They're going to have issues with their self-image, and they're going to have marked impulsivity. So they don't think before they do things. They make rash decisions. They can become very irritable, even hostile or sarcastic, and they may complain to you about having episodes of panic anxiety, so panic attacks. They rarely experience periods of satisfaction or well-being. So these are people who always have some type of an issue. You know, it's that person that's on Facebook that posts 5 or 6 posts a day that it's never anything positive. There's always something going on. Somebody's making them mad. Something terrible happened. It's just all negative. They report intense loneliness. They always feel like they're by themselves. They might feel boredom. They might actually feel frustrated with their situation and the people around them. And they might report that they feel empty, like something's just missing. They have a very dysphoric mood. So they have this profound sense of just feeling uneasy, like something just doesn't feel right, or they're just always dissatisfied. They feel very unhappy. They feel restless. It's hard for them to sit and relax. Or they also may report malaise. They have polarized extreme thinking, which is splitting or dissociation. So this is where you have, it's the inability to be able to hold opposing thoughts, feelings, or beliefs, or disassociation where you remove yourself completely. So it's a defense mechanism that people with borderline personality use. They can view people, events, or even themselves kind of like in all or nothing. So it's either going to be, you know, there's just no in between for these people. It's kind of hard to describe. But so if, I don't know, say your best friend's getting married, and, you know, when people go through marriages and when they have babies and things like that, you start to see some sides of their personalities that maybe you didn't see before. They become a little bit more needier. Things become about them. Well, for these people, they wouldn't be capable of looking at their best friend and saying, oh, you know, she doesn't usually act like this. It's probably just because she's stressed. You know, she has a lot on her plate. Her wedding's in 2 weeks. She's got a lot going on. You know, it's all about her. With these people, they would say, you know what? I can't even believe I've been friends with her this long. This person's completely terrible. I can't be friends with you anymore. So it really is all or nothing. There's no in between. There's no working on things. There's no recognizing things, thinking that they'll change. It's very drastic. When they do what's called splitting, it allows them to readily discard things that they have assigned as bad and to embrace things that they consider good, even if those things are harmful or risky. So once they get that behavior in their mind, with the example that I used about the 2 friends and the one getting married, once that person believes that she's not a good person anymore, that's it. She's completely done with it. And then once they find something better or something good in their life, they embrace it, they hold on to it, and it consumes them with everything that they have, even if it's harmful or risky. It's not always a good decision. So we want to make sure when we're assessing these patients, we're going to be looking for patients that have excessive or chronic fears of abandonment. So they will, they may have had some severe abandonment issues in their life, or they just always have a fear of it. So when you're talking about things, you really kind of have to point out to them, especially if there are fears, you have to make them realize that they're fears. So you kind of have to talk them through things. Well, why do you feel this way? And then you have, you know, well, I feel this way because, I don't know, it's the way he looks at me or the way he doesn't help around the house. I just think he's thinking about leaving me. Well, what other things does he do? Well, he does do this. And well, when do you guys talk? Do you have dinner together? So you kind of have to just like talk through things with them and get them to realize that they're just fears. So you have to kind of point out positive things that are going on in their life and positive things if you're dealing with, you know, a husband and a wife or friends that are just having issues, because they need to be able to realize that they're just fears and that there might not be any valid reason for them. They might present with impaired judgment, so safety may not be a concern for them at all whatsoever. They may be spending all their money, not paying their bills, they're gambling, they might be stealing that instant gratification. They may drive reckless. They also may threaten to hurt themselves or self-mutilate. So this would be cutting themselves, punching themselves. Burning is also something that we see very commonly. These are usually cries for help. They want attention. And then when they do it, the physical pain that they feel takes away from the emotional pain that they feel just for that present time, because they're in so much pain they can't think about what's going on in their mind. They may appear needy and dependent one moment, and then they can be completely opposite the next, very, very angry, very hostile, and they can reject everybody around them. And then this cycle just repeats itself. They also may self-isolate. They might stay in their house, not come around anyone else, just go to work, come home. They lack the concentration and self-discipline to follow through on sometimes just the most mundane tasks, with work or school. So showing up for work on time, completing the most basic tasks, doing homework, things like that. So data analysis, some of the nursing diagnoses that we might see: risk for suicide, risk for self-mutilation, risk for other directed violence, and then, of course, there's ineffective coping. And treatment outcomes will be that the client will be safe and free from any kind of significant injury. The client will not harm others or destroy any property. The client will demonstrate increased control of impulsive behavior. The client will take appropriate steps to meet his or her needs. The client will demonstrate problem-solving skills, and the client will verbalize greater satisfaction with relationships. So interventions that we can do. So when we are promoting that safety for our patients, we can have them sign what's called a no self-harm contract, where it is just that. It's a written contract between you and them. It's usually anyone that's involved with the patient, as far as, it could be the nurse, it could be the therapist, it could be the person just prescribing the medications and the patient. And you clearly spell out, I want you to abstain from doing this, this, and this. You will not, injure yourself in any way for a period of, X, Y, and Z. And then you want to encourage this safe expression of feelings and emotions, because really when they're doing self-harm, it's that they're not able to express their feelings and their emotions. So we want to really encourage that. So building that that therapeutic relationship, that trusting relationship, so that they feel safe and they can express those feelings, so that they don't want to do things to harm themselves. Promoting the therapeutic relationship, limit setting, making sure that we don't encourage or allow unacceptable behaviors, making sure that we are keeping our end of the bargain and making sure we meet with those clients for those scheduled appointments, establish boundaries if we have to, teach effective communication skills, so using those I statements, help clients to develop and control their emotions. So you want them to be able to identify their feelings when sometimes they just get angry and they lose control, and they're not even able to determine when that happened. All of a sudden, they're just in this massive state of anger, and before you know it, they're throwing things around the room. So you want them to identify things that they might feel before they actually reach that state. So do they feel sweaty? Is their heart racing? Does their head start to pound? Do they notice that they start walking around? We can encourage them to make journal entries, especially when they're starting to feel a certain way, whether they're anxious or they're scared. And then we want them to really work on implementing techniques that will curtail that negative behavior. So when I feel myself getting angry, when my heart starts to race, I know I'm getting anxious. I need to take 5 minutes for myself, think about 3 things that make me happy, count backwards from 50 till I get to 0, take a couple deep breaths, whatever helps them to be able to control that emotional response. And then we want to rethink those thinking patterns. So thought stopping. So when they start thinking negative thoughts, harming themselves or other people, stopping in that moment, decatastrophize. That is a big word to say. Decatastrophizing. I don't know, I'm saying that wrong, which is learning to assess situations realistically rather than always assuming that a catastrophe will happen. So some students, they go from zero. I mean, some patients go from 0 to 60. There's really no build up to it. It's not like I feel this way and I think this is going to happen. It's that I'm feeling this and this happens. And then they think that everything that happens is going to be catastrophic. It's going to be the end of the world. So you want to do a lot of positive self-talk with these patients, build up their esteem, make sure that if you've seen them implement things in the past to handle their emotions or to stop their thoughts, that you focus on them and let them know how good that is so that they will continue to use those strategies. Structure their daily activities. So we want to keep these clients busy. Idle time for these patients is not good. It allows them time to think. So we want to make a written of their schedule of activities for the day, make sure they're following that schedule. And we know that sometimes when they're bored and they're thinking, that bad things happen. So we want to make sure that we also, for your antisocial patients, we can do activities where they can be by themselves, but where they're not thinking. Evaluation. So we have to remember that it's very hard to change somebody's personality. So if we start to see any improvement, the changes are going to be very small and very slow. Clients with severe impairment may be evaluated just in their terms of their ability to be safe and to refrain from self-injury, because that might be the only thing that you're noticing at the present time, but that's still a huge thing and you need to recognize it. Other clients may be employed and have fairly stable interpersonal relationships. They may report that they're getting along better with their mom, or that their and their husband didn't have, any fights this week, that they went to work every day and didn't have any issues at work. Generally, when the client experiences fewer crises less frequently over time, treatment is considered to be effective. So related personality behaviors that we see, some of our patients also present with depression. This often occurs when relatives who have, in families where relatives also suffer from depression. There are persuasive depressive cognitions and behaviors, which are less severe than major depression. Pessimistic, negative thinking, so it's really hard for them to see the light at the end of the tunnel. They really don't think that therapy is going to work. They don't have, like any hope or any faith in a lot of stuff. They usually think negative. They don't say anything positive. They have a low self-esteem. So nursing interventions for these people, we want to, of course, keep them safe, because we know patients that have any type of depression are at a high risk for developing, attempting suicide. So we want to keep them safe. We also want to keep them involved in activities. We don't want them to have any idle time to think. And then we want to be factual with our feedback when we're talking to them. All right, so we're going to talk about a couple other personality disorders that we could see. So we could see passive aggressive. So this is the clinical picture of someone who's passive aggressive, is they may initially appear very cooperative, even if they're sullen or withdrawn, their mood will fluctuate rapidly or erratically. And then you might notice that they get extremely upset or offended with, like, for no reason at all, after they were just being cooperative. Sarcastic, they might procrastinate doing things. They'll appear to have a negative attitude. Passive resistant to demand adequate social and occupational performance. So they may, like in the workplace, they may appear as being very respectful, but they're not, they're resisting what their employer is asking of them, but they'll just do it in a respectful way all the time, so it doesn't come across as them being non-compliant. They're going to blame other people. They're not going to really own up to their part in any of the issues that they have. So what do we want to do as nurses? We want to focus on, we want them to be able to identify their feelings, and we want them to be able to express their feelings. Those are the main things for someone who's passive aggressive. Then we have paranoid. I don't know if you ever have encountered anyone who has a paranoid personality. These people can be very, to me, it can be very scary. It can actually make you feel unsafe. So these are patients who do not trust anyone at all. They're always suspicious about everything that's going on. They use a lot of projection. They usually conflict with authority. They may be unable to demonstrate any kind of warmth or any kind of emotional response. And they tend to have a significant history of having lifelong problems and being able to work with others because they always think that somebody else has an agenda. So I had been taking care of a patient. Actually, since I've been a nurse, I've taken care of him on 3 separate occasions. It's just so bizarre that I end up being floated to units where this person is. And I always am like a believer that everyone ends up in your path for a reason. So I don't really know why I've encountered this person 3 times, but he has this paranoid personality. He's actually a veteran and he has PTSD, and it manifested so bad in his life that he lost his family. He doesn't have a relationship with his kids. I think they were kind of taken away from him because he wasn't mentally stable. It's really sad. But every time that he came into the hospital because he thought that his neighbor was trying to poison him with gas in his home. And he would come in saying that he had chest pain and he had trouble breathing. And he would ask to have all these x-rays because he knew that his lungs were damaged. But he was very, very, to me, unstable the whole time. And he was even nervous of what I was doing. What do you have in the cup? What kind of medicine is that? I need to see the package first. So I feel like being aware of your own self in these personalities and what makes you feel uncomfortable is a huge part of being able to care for this population of people that have this paranoid disorder. So nursing interventions, we need to be very formal and very business-like when we approach them. We want to try and break things up and kind of have like some kind of social chit chat because we're building that therapeutic relationship. But for these patients, they view it as you having an ulterior motive, that you're being only nice to them because you want to kill them, or you are going to try to convince them to take their meds. So that's why you're being so nice. They always have to feel like they're in control. So they're going to want to do everything. So you want to make sure you're involving them in everything, because if they're involved in it, then they have control over it and they know what's going on, and then nobody can hurt them. You have to do ideal validation before action. So clients can avoid problems if they refrain from taking action until they have validated their ideas with someone else. Then we have schizoid personality. So these patients are going to present with social detachment. They're going to have a very constricted affect and little, if any, type of emotional in interpersonal settings. They're going to be very hard to read. They're not going to show you really any type of emotion, but they're going to be a very, very intellectual. They may appear self-absorbed. They often are by themselves. They don't have a lot of close relationships with their family or long-standing friends, and this goes through every aspect of their daily life. And then nursing interventions for this personality, we would just want to, because there's so much social detachment and a lack of emotion, we just want to help improve their functioning in community. So maybe going into the community to some type of group setting is where you would start. And then, maybe getting a job, working, going to the grocery store, things like really being a contributing member to society. So the schizotypical personality, so this would be, they would present with social and interpersonal issues, problems. They also have a reduced ability to be able to form these really close relationships. They have different behavioral eccentricities. They have cognitive or perceptual distortions. They will have a very odd appearance that causes other people to notice them. So they can be what's considered very flamboyant. They might just wear really different clothing, really bright colors. Maybe they'll be dressed in a really long sleeve, heavy dress when it's 80, 90 degree weather with a hat and gloves. Their appearance is going to cause them to be noticed by other people. They may be completely unkept, so their clothes may not match. Their hair might not be done. Their teeth may not be brushed. Their clothes may not fit. They could be stained or dirty. It looks like they've been wearing them for, several days or weeks at a time. They may just wander around aimlessly. They don't make eye contact with anyone. They don't interact with anyone. And they sometimes appear to get like preoccupied with things in their environment. It could be anything. It could be a bird. It could be a car. They can experience transient psychotic episodes whenever they encounter any type of extreme stress. This disorder can also develop into schizophrenia. There is an inability to respond to normal social cues. So normally if you're walking down the street and you talk to someone and you say, "Can you tell me where Martin Road is?" They will not respond like most people normally would. They may just look at you in a strange way. They might not utter any words. They're going to appear odd. They may have a lack of ability to express a full range of emotions, so they might not be able to express anger, happiness, and pleasure. Maybe just anger. Maybe they might just have a very flat affect. So nursing interventions, what we're going to focus on is we really want to focus on that self-care. So we want them to be able to shower every day, wash their hair. We want them to brush their teeth. We want them to, we want them to have control over what they wear in their wardrobe, but we want it to be clean, which should be fitting properly. Should it match? I guess so, according to who. Some people think it's completely okay if your clothes don't match. So I wouldn't really worry about that. But definitely, taking care of yourself, hygiene, social skills. So group therapies are good for this. What to do at a dinner table, at a lunch table, how to interact with other people, how to ask for something when you need something, and then really teaching them how to function in the community. So this is the histrionic personality disorder. So these patients are very overly concerned with impressing others with their appearance, and they spend a lot of time and energy and money to make sure that this happens. They have excessive emotionally and attention-seeking behaviors. They are not usually very sincere. They are very dramatic and over-exaggerated. They always have to be the center of attention. They have temper tantrums when they don't get their way. So if somebody else is getting attention instead of them, they'll have a temper tantrum. That's important for you guys to know that they have temper tantrums. Exaggeration of relationships. The way they describe their relationships with people probably are not the way that they actually are. And then nursing interventions. So we want to give them feedback about their social interactions. We want to be honest with them. We want to teach them appropriate social skills. We want to do this through role playing. So instead of saying or doing this, how about if you say or do this? You might get this behavior. So role playing is great for this personality disorder. And then of course, you always want to establish and explore their strength and their assets, because you don't always just want to focus on the negative. So this is a clinical picture of a narcissistic personality. So they usually have some type of grandiosity, fantasy, or behavior. They always have a need for people to admire them. They want everyone to love them. They have to be the most loved. They're usually very ambitious and very confident, but they don't usually have any empathy towards other people and situations. They can be extremely arrogant, have an arrogant attitude. They kind of have like a superior view of, there's no limit to how much success they can have, no limit to how much power. There's no limit to how brilliant they can be. They're the most beautiful. They're the ideal for every situation. They always have a sense of entitlement, and they have an unrealistic expectation of special treatment. The rules don't apply to them. Well, I'm so-and-so, so this should happen for me. Or an automatic compliance with wishes. But they can also inside be very fragile, very vulnerable, and have a low self-esteem. So patients that have avoidant personality disorder, so they're going to have social discomfort, low self-esteem. So they don't place themselves in social situations. When they do, they don't feel confident about it, and it makes them extremely stressed out. And they'll avoid it at all costs because they don't want to have the anxiety that surrounds putting themselves in that situation. They might have a very hypersensitivity reaction to like negative situations and people viewing them negatively. They may appear shy. They may also appear fearful. They can also be described as what we call socially awkward. And then we said they avoid unfamiliar situations and people at all costs. So they really don't try new things and they don't go a lot of places. So nursing interventions, we really want to work on self-affirmations. We want them to see themselves the way other people see them. So we want to point out their good qualities and remind them of everything that they do well and all their good qualities. We want to teach them to think positively about themselves. So we want them to engage in making lists about things that they think are good about themselves. And then we want to focus on those things. They need a lot of support and a lot of reassurance. And then we can work on those social skills again in group therapy through role playing. Then we have the dependent personality. So these are the people who cannot be without other people. It could be a husband, a mother, a wife. It could, they even do it to their children. They need to be taken care of. They're very submissive. They're very clingy. Nursing interventions for this personality disorder is that we want them to have the freedom to express their feelings. We want them to have autonomy in their care. We want to do like this cognitive restructuring where we sit with them and we try and put them, remind them of the situations that make them uncomfortable so they can see, how they start to feel when certain things happen so that they can recognize that and they can figure out ways to solve the problems without being dependent on someone else. So when I recognize this feeling and I feel this or I see this, what can I do to change it instead of going back to the person that they're so dependent on? Obsessive compulsive disorder. So this is the person that has to be perfect. Mental and interpersonal control. Their demeanor is usually very formal and serious, and they answer questions with precision and much detail. They can also be very stubborn and reluctant to relinquish control. They always have to be in control because they're obsessive. They're expected to be good and do the right thing and to win parental approval. So they will say that as they were growing up, that their parents always made them. They had to be perfect. They had to do this. They had to keep their room a certain way. Their drawers always had to have this, that, your socks in this drawer, your shirts, everything had to be lined up. Everything had to be perfect. And they had to do that in order to please their parents. Orderliness is a priority. So things have to be in an orderly manner, but any type of efficiency and flexibility kind of goes out the window. So if you have to be late to work to make sure that everything is orderly, that's what has to happen. If you have to walk around the house and make sure the stove is off. So this is kind of like more of a compulsive part, but you have to make sure all your windows are checked. You have to turn your door handle a couple times. They do like these rituals is what they're called. That's the compulsive part of it. They will have to do these things at the expense of being late for work, and flexibility. I'm trying to think of another circumstance. So sometimes I knew a girl who had to do all these things before she left the house, and I worked with her. And one day she got halfway to work and called me and said, I have to go back home. And she was like, I didn't turn the door handle and I don't think I shut the screen door. I have to go back home again. Well, she couldn't come to work until she went and home and did that. So it didn't matter that she was late for work. It probably cost her a job at some point because she wasn't very dependable. So being orderly and have everything taken care of and in its place is a priority for them. They have problems with decision making when it comes to making judgmental decisions. They have low self-esteem, so very few friends and a little social life. So nursing interventions, we want to help develop another perspective for them. They need a lot of cognitive restructuring, and we want to encourage them actually to take risks because these people will never ever take a risk, usually because they think if they do X, Y, and Z, that something else will happen. And usually medication, that should probably be on here too. These patients can definitely benefit from medication and interpersonal or group therapy. All right, so promoting mental health for our patients. So unmet needs, so self-care, when we, we want them to be able to take care of themselves. We want them to have clean clothes. We want them to shower every day. We want them to be able to sexually express themselves, feel comfortable doing that with whoever they're in a relationship with, if they're married or they're just in a healthy relationship with someone that they love. We want them to be able to budget, manage their finances, go to the grocery store, not overdraw their bank account. We want to diminish those psychotic symptoms, anxiety, depression, hallucinations, things like that, and we want to decrease their distress. Typically, psychotic symptoms and psychological distress are often the only areas that are addressed by healthcare providers. So patients will come in and we'll talk about the symptoms that they're having. We may give medications for them and talk about strategies to avoid them. We'll talk about the different distress that they're feeling in their life, but then we might not talk about the fact that they can't budget a checkbook and that they're overdrawing their account every week, or that they can't have a normal sexual relationship with their loved one, because all these things are getting in the way. So we want care for the first 3 areas are important, because we know that if they can maintain self-care of themselves and have good hygiene, and if they have good sexual expression in their relationships, and if they can manage their money and pay their bills, these are going to contribute to an overall sense of them having, improved health and a good mental health outlook on things. They're going to be happy about things. Children with a greater number of protective factors are less likely to develop antisocial behaviors as adults. And then emphasis of care on protective factors of, so school commitment or the importance of school, parent and or peer disapproval of antisocial behavior, or involvement in religious community things. So that is just basically, so, this is just saying that as parents, that if you're telling them, you're having them join soccer, you're having them join Brownies or Boy Scouts, they're being in some type of school commitment, they play in the band, you've always told them of the importance of school, so they've graduated high school, they go on to college, you never really have approved that antisocial behavior. You've allowed them to be well-rounded. So you're taking them to church every week. Maybe they went to Bible school. So basically, if you've instilled those things, they believe that emphasis on those areas will less likely develop, those children will less likely develop antisocial behaviors as adults. And our last slide. So of course we have to have self-awareness. So we have to avoid patient attempts to manipulate us. We have to recognize them and avoid them by limit setting. We have to use clear communication. It's going to be necessary to reframe, to remain firm and consistent about what we expect for our clients. We have to set those limits and boundaries. And we have to deal with frustration. So patients, we said, if we see any change, it's going to be very slowly. You may see more potential in them that they see. So you may have higher expectations of them, but you can't let that frustrate you. You just have to know that this is the type of thing that doesn't change very quickly. So you can't really get frustrated with these patients, regardless of what you think they're capable of. And then you want to make sure that you're working effectively as part of the team, and bringing everything that you can to the table about the patient to make sure that everybody's consistent and they're getting the best possible treatment. All right.